Back to my roadie days. Yeah, all right. So good morning. I'm Dr. Chris Ohl with Wake Forest Baptist Health, and we're here to talk about COVID-19 again. So welcome to Peak Week. So I think the word peak, if you Googled it, would probably be one of the biggest words that have been used over the last week. And why is that? It's because a lot of our large urban centers are, quote, peaking in their epidemiology curves. And if you remember, if you had tuned in last week, we talked about how an epidemiology curve looks a little bit like climbing a mountain with the number of cases per day. And then that eventually the number of cases start to decline again per day, and then that is called your peak. So New York is peaking probably right about now, if you look at their epidemiology curves. San Francisco, I think, is already peaked, and Seattle is already peaked, and they're coming down their curves. And in fact, California and Washington State have decided that their number of infections are declining enough that they can actually share some of their ventilators with other hard-hit states. So that's good news, that the places that were first hit have come up and over their peak. It gives us a little bit of an idea of timelines. So New York remains still our hardest hit urban area, both as far as deaths and as far as numbers of cases. And we've talked about in the past that has something to do with population density, and it also has something to do with they had a fairly large number of cases there before they started to do their shelter in place. Here in North Carolina, everyone wants to know, when are we going to peak? When are we going to peak? And I think as a state we're getting close. It'll probably be in the next few days. We'll have to wait and see, but it looks like that as a state we're starting to round off some on the number of new cases per day, and we'll have to wait and see over the next few days. So after Easter, we'll know for sure if we've come up and over the peak. Certain areas in North Carolina are being hit a little bit harder than others, as we've talked about. Mecklenburg County and the Charlotte area remains the leader for numbers of cases, numbers of hospitalizations, numbers of ICU hospitalizations. But they also look like they're starting to round off the top. So some good news here in the state. Now in the Triad, everyone wants to know, when are we going to peak here in the Triad? So I don't think we are going to have a peak. I hope we don't have a peak. Looking at our curves, we're having roughly the same number of cases per day. New cases per day, the same number of new hospitalizations per day, and the same number of ICU admissions per day. So we came up like this, and we're going like this. We're a mesa. If you know what a mesa is, it's those things out, those plateaus that you see out west. And that's a good thing to be, because it means that our healthcare facilities don't end up becoming overwhelmed like what we saw on TV in New York and what we heard about there. It also means that we can keep our cases lower so we can protect our vulnerable people, the older and those with comorbidities, because it's a lot better to have a controlled epidemic than an uncontrolled. The one downside about being a mesa, if you've ever been out west, is that you can walk on the top of a mesa for a long time before you get to the other side. So I think it means that our numbers of cases and how they go are going to last longer here in this area. And we're going to come back in a minute as to what that means as far as exit strategies. So the thing about COVID-19 right now in our area is that we are sheltering it in place. And last week I said that social distancing and sheltering in place, I said that, you know what, I think it's working. This week I'm going to say sheltering in place is working, all right? I am confident it's working. And all of the areas where it's been able to be done appropriately and properly, it works. And it is really working here. And every single one of us in infectious diseases who follows this really thinks this is it. So what does that mean? It means that the little bit of pain that we're going through is worth it, because it's protecting our vulnerable people, it's protecting us, it's keeping our health system from becoming overwhelmed, and it is actually enabling us to have some other activities that we can do without being worried about them. So you can go outside, and you can do outside activities. We're still able to get takeout food and do those things that we have to do. You can go to the grocery store, not quite as worried as what you would have to be as if you were in a widespread community transmission. It means that our community transmission is just not as high, and that we're keeping it down because we're sheltering in place well. Congratulations, Triad, okay? I am so proud of everybody for doing this. And I know it's not easy, and I just want to give a shout out to our young people, to our kids, to our college students, and to our high school students who are having to go through this, because kids are really the social animals, and this is hard. They miss their friends. They're looking at what's going to be going on with graduation. How am I going to get my grades? Hey, I really want to get into college. Is this going to affect me getting into a good college? And so they are really coming too. So everybody congratulate a kid today, okay? Because they're the ones who are really, really shouldering this, I think. So what kind of activities are still okay to do in shelter in place? Well, we talked about last week outdoor activities. Playing tennis is great. All our tennis courts are open. I talked with our county last week. We're keeping Tanglewood open. We're keeping our other parks open in the county. Winston-Salem's doing the same. Playgrounds are closed because this is where people congregate. The people ask me all sorts of questions about being outside. Hey, you know, I'm mountain biking. I go down the trail this way, somebody comes up the trail this way. Do I have to worry that that's not, you know, social distancing? Actually, when you're outside doing these kind of activities and the air is all around us and the wind is out there and you're moving, the air exchanges are so high you really don't have to worry about exchanging viral particles or goblets with other people in that setting. And then if you're out walking on the greenway, most of the time the people that we're walking with are our spouses and people we're living with. You're already together anyway, so you can stay together. But otherwise, just keep your 6-foot distance on the greenway, and we can do that in our area. We're not quite as concentrated as New York, for instance. So I think being outside is fine, and it's a great place to be. What are we going to do as time goes on with our sheltering in place? Well, this is the big open question. And over the last week, since we've talked about since last week, we've had some social distancing information that's come from modeling. And what is modeling is when the statisticians all get together in a room and they get out their computers and they try to figure out how many cases based on solid epidemiology statistics we're going to see. And for the next month here in our area, the Triad area, and most other areas in North Carolina, it's going to depend about what we do with sheltering in place. And there's two models. And if we keep sheltering in place throughout at least half of May and getting in towards the end of May, and then we relax it before Memorial Day, we're going to be golden. And our mesa will just kind of keep going like this, and then eventually it'll come down and it'll fall off by the end of May. And that means our healthcare systems won't be overwhelmed. It means we can do that controlled protection of our vulnerable people, kind of like, you know, going down a big snowy hill on a toboggan. You want to do it in a controlled way. No one wants to ski or toboggan out of control, so you want to come down in a controlled way. if we release our shelter in place according to these models by North Carolina epidemiologists and statisticians throughout our academic centers, if we release that sheltering in place at the end of April and towards the beginning of May, the models show that we would have a bit more than a 50% chance of our intensive care units becoming overwhelmed in our hospitals. And that's a little bit like New York. Not quite as bad, but we're getting there. 50% probability. So it's kind of like a weather forecast, right? 50% chance of having a storm come through tonight. Well, class that we do everything we can to keep our population safe. So we would advocate keeping monitoring and social distancing going until the end of May. There are other things to think about, though. Economics, our economy, our businesses, and just everyone longing for a normal life again. So we're going to have to see where that balance comes out. And that's what's being discussed. So part of the exit strategy, actually, for getting off our mesa also is going to involve going back to containment. So right now we're in mitigation, which means we do things to keep things pushed down. Containment means that we relax things and then we go back to identifying cases and then isolating all of the positive cases done by testing and then quarantining the people around those cases. And that's going to require some stick-to-itiveness for those people. In a sense, it's trying to contain the virus by people who we've tested and know they're positive, rather than keep everyone at home. We just keep the infected people. Will we have enough tests by the end of May to do that? Probably, but we're going to need to really beef up our public health corps to identify people, and people are going to have to stick to their isolation. If they're tested and they're put in isolation, they're going to have to stick to it. So that's a potential exit strategy. So to see if we can get off our mesa by the end of May. So we'll see. We'll see what our community leaders and state politicians decide about when to release and how to do it. But personally, I advocate for doing it in a controlled way. And again, I really want to congratulate everybody for hanging in there with this, because it's working and it's keeping us safe. So a few other things to bring up that have come up over the last week. Testing is ramping up. We're able to now test all of our inpatients fairly easily with a fairly rapid turnaround time. Those are the people we're admitting to hospitals or in the hospitals. And we're being able to test more healthcare workers who get sick, and that's really important because we want to identify healthcare workers who might have COVID-19 so that we can know when to bring them back to work. The other thing that's a little bit new and different, everyone always wants to know about personal protective equipment. Do we have enough of it? We're staying ahead of it. In fact, we're making a little bit of progress and getting a few more days to weeks out at our current use rates. So we keep track of it still every day, but so far so good. And if we keep on a mesa and we don't let ourselves relax off and go back up again, I think we're going to be fine with personal protective equipment. Number of ventilators, yep, we got enough in the state, not a problem. Hospital capacity, so far so good. Charlotte's hospitals are fuller and a little busier, particularly their ICUs. But if we stay on our mesa and don't let it get out of control again, we're going to be fine there too. And if we have a contingency that we need to help Charlotte out, everyone, I think every hospital who would have capacity and relationships with them would do that, including us. So, so with that, I think I'll just open it up for questions and give you guys a chance to see what's on your mind.
Whenever it comes to containment, can you talk a little bit about or explain the process? Because this is a question that we've been asked. how do you guys go about notifying those people that may have come in contact after a person that they had been around tested positive for COVID-19?
Right. So what's the process of identifying somebody who may have come in contact? So right now we're not doing that, right? We're doing mitigation for the most part. So right now, if you get sick with a flu-like illness and you would normally stay home with your flu-like illness, just do that. Stay home with your flu-like illness. If you think the symptoms are more severe or you have underlying medical problems or are older, then call your doctor and ask them what to do and how to monitor yourself for getting more severe symptoms. You don't need to be tested. And that's our strategy across the whole state right now. And it's not different per county, it's the same all across the state. And that strategy is a good one. I mean, it works as long as people are honest about it and you stay home for 7 days with 72 hours of improving symptoms. Once we start to come down off the end of the mesa some, then that's when we might go back to, if the strategy is, that's when we would go down to containment. And so then we would open up testing again and would say anyone who's sick should go get tested. I don't think we're going to be testing people without symptoms, just people who have symptoms of flu-like symptoms. And then if that test comes back positive, then you're put in isolation for 7 days. And the way we contact the people around them is we ask the person, okay, who do you live with? Where do you work? Have you been to any parties lately, even though you're not supposed to be? And then we find out those people, and then the public health contacts them. So it goes through the county health departments. And those people are then quarantined. The difference between isolation and quarantine is isolation is staying home when you're sick. Quarantine is staying home when you are in contact with somebody who is sick, waiting to see if you get symptoms. So we kind of build a cocoon around that case, so to speak. And that's the concept of containment.
And is there any monitoring of those people that are supposed to be in isolation or in quarantine, I should say?
Yeah, so if you're in quarantine, is there any monitoring? Right now we do what's called self-monitoring, which means we tell you to take your temperature every day and then give us a call if it goes up or if you get symptoms. There is also active monitoring, which means you're going to get a phone call from somebody, a virtual visit, so to speak, to check in on you and see how you're doing. Real active quarantine goes back to some people will remember to the 1940s and 50s, like with polio, where you get a sign, tapped onto your front door and you get somebody kind of looking at your house. I don't know if we're going to be doing that in the U.S. Other countries do that. South Korea puts soldiers on the doors of people who are in quarantine, but I don't think that's the American way. So you have to be a good citizen and patriotic about it.
Hydroxychloroquine.
Good stab at that. Hydroxychloroquine. Yeah, it's a word no one knew before, right? Yeah.
Some people tout it. Some people say medical experts, I think, use caution. Your thoughts?
You want to know where I sit on it? Use caution. I'm not a touter of hydroxychloroquine. I've been doing infectious diseases now for almost 30 years, and I've seen so many things come down as, quote, miracle cures, particularly for viruses, that after the study's been done and everything's been sorted out, they weren't at all. So I think hydroxychloroquine's worth exploring in a clinical trial, which means you enter somebody into the trial and see, put some people on it, some people not on it, change the dose around a little bit, and then you look and see where the data lies. And Tony Fauci, who everybody knows, right, which is the guy you see with President Trump on TV, from the NIH, he also agrees with that. A clinical trial would be the way to go. Now, I'll tell you, not everyone agrees with me. They say, hey, what harm can it do? Well, it can do some harm. It needs to be closely monitored if you're going to use it.
As far as Cpaps as ventilators, are they safe to use if needed in emergency?
So is a Cpap type ventilator safe to use in emergency? Well, in the hospital, we would prefer not to do that. It comes down to, if you need to ventilate somebody, you ventilate them. You put a tube into the lungs and put them on a ventilator. Cpap or something called BiPAP, which is a form of Cpap, may not work as well for COVID in the hospital. Now, if you're on home Cpap, which a lot of people are for sleep apnea and things like that, it's safe to continue to use it, yes. And so no one is advocating people to stop using Cpap if you're on it at home. It's more of a consideration for us in treating sick people in the hospital.
And how would the CPAP work differently from the ventilator itself?
So CPAP, how does it work differently from a ventilator? Well, a ventilator breathes for you whether you want to or not. So it basically takes over your brain and lungs to make sure that you get a breath and that the oxygen gets into your body through that. What CPAP does is puts a little bit of positive pressure into your own breathing to help keep your airways open. So it kind of makes sense if you think about a straw in a balloon, right? If you suck on a straw, the straw collapses and you don't get it as much. If you blow with some positive pressure on the straw, it keeps it open. So it helps keep airways open for people that sometimes their airways close off. And sleep apnea is the big thing that it's used for at home. So they're two different things.
What would you suggest? Would you use a CPAP in an emergency situation? Why or why not?
Well, generally in an emergency situation, for us as healthcare workers, what we would do is intubate the patient and then breathe for them using a ventilator or a bag rather than using CPAP. Because CPAP, the person has to be breathing and capable of breathing on their own for it to work.
So with the COVID-19 patient, they wouldn't use that in an emergency in any way?
Not for a COVID-19 patient who's really having trouble breathing. We wouldn't use CPAP for it. We would use intubation and ventilation, or maybe something called BiPAP, which is different. Some technical things. We'll get you into medical school.
There are reports that CPAPs might actually spread the virus when using it. Is there an explanation on how that would happen?
So how can CPAP spread the virus? It's because when you're putting positive pressure in the airway and the person's breathing and then the air breathes out or the air comes out of the machine, it can spread it in a system. And that's one of the main reasons we don't like to use it for COVID-19 in the hospital. At home, it's really not a concern.
Can you explain, area hospitals are reverting to where staff, regardless of whether or not they are in contact with patients throughout the day, they are wearing PPE equipment. Here at Wake Forest, what is the procedure like? Is it any different than that?
I think most hospitals in North Carolina are kind of doing the same thing now and at least using a mask and encountering all patients. And it's simply because you don't really know what you're getting into until you get into it when you're talking to a patient. Also, if you put a mask on a patient with a respiratory illness and then you're wearing a mask and then the patient ends up having COVID-19, then your exposure is going to be very minimal and not nearly as worrisome as if you weren't wearing it.
So staff here at Wake Forest, regardless of if they are having a patient contact, are they always wearing safety masks?
Yeah, in most instances. I mean, there's some exceptions, but yeah, in most instances they are.
And what would those exceptions look like?
Well, as if you knew, for instance, if you knew that the patient has been in the hospital and has been tested and is negative, it wouldn't be as necessary. But the thing is, healthcare workers move around, right? They're a little bit like hummingbirds if you watched them. They go work over here and then they go work over here for a while and over here. And when you're doing that and you're going back and forth, it's just easier to leave the mask on. And also you use less of them because you can leave the same mask on for your whole time on that shift, and you don't have to be changing it out all the time. So it helps us conserve PPE, and it's safe to do. So, all good questions. So I got one here. It says, seems like quite a number of younger folks under 50 are dying. Why? Well, when you look at all of the total numbers, by far and away, the numbers of deaths are greatest in people over the age of 75. And over 80, it even goes up more. And so if you look at numbers of deaths per, and you divide that by cases, which is called the CFR in epidemiology, the case fatality rate. The case fatality rate for young people under the age of 50 is probably somewhere around 1%. If you're under the age of 30, it's probably about 0.5%. And I'm kind of fudging the numbers a little bit, but somewhere in that range. If you're under the age of 20, it's really low. It's down like 0.2%, 0.1%. If you're over the age of 75, the rate's a little over 10%. So what does that mean? It means the older you are, the more likely that you might have a death. But when you think about these numbers, they're still all pretty low, right? I mean, comparatively, they're all pretty low. So if you look at any one particular person who gets COVID-19 and the threat to you, the threat is still low, even if you get it. Even if you're older. I mean, the odds are much greater that you're gonna survive and recover. It's just that we in healthcare want to know who our most vulnerable and our highest risk people are, because those are the ones that we try to protect the most. So yes, there will be some deaths in young people due to COVID-19, some, but the likelihood's very low. And unfortunately, young people die of infectious diseases all the time. I mean, you can die of strep, you can die of other bacteria, meningitis. I mean, it happens. It's very unusual, but it gets your attention, and so that's why I think people are saying, "Look at all the young people dying." But when you really add up the numbers, it's not so many. And then, am I worried about a second wave? And then if I am, what might it look like? Timing? Will we be better prepared? Yes. Next question. So second waves. So epidemics tend to come in waves, just like those waves out in the ocean. We're talking about some areas peaking, some places having mesas, and maybe by the end of May, things will be looking a little better on this wave. If and when the next one comes, when will it be? Well, my crystal ball gets a little fuzzy the further out I look. I think a lot of people in infectious diseases who think about epidemics and emergent infections are worried that we might see it again in fall when the usual respiratory flu season comes back around. COVID might come back then too. And how that wave looks will depend on a lot of things. It'll depend on our level of herd immunity, so how many people have gotten the infection during the first wave that would protect them during a second wave. It'll depend a little bit on how fast communities might jump on social distancing and shelter in place again if a second wave comes. And then it'll depend a little bit on how well we're able to test and do containment. Because if we can test and do containment at the beginning of a second wave, we'll have a much better chance of controlling it. So we'll be looking for that second wave. Could it come earlier? Yeah, it could. Could it come later? Yeah, it could. Could it never come at all? I guess it could, but you have to kind of plan for it. Will we be better prepared for it? Yeah, I think we will be. Certainly with testing we will be. And PPE we will be, and we'll have learned some lessons from this one. So we'll be a lot better prepared for the second wave if and when it comes. But a second wave makes planning hard for, particularly like for universities, school systems, the NFL. So it's a big open question. I wish my crystal ball was a little clearer.
I want to ask one more question, going back to the notifying of people that may have come in contact with somebody who was later diagnosed with COVID-19. Whenever it comes to them being notified, what all information are they given? Are they specifically told who it was that they had contact with that had COVID-19? What sort of resources are they given as well?
Right, so if you're a contact of somebody who's had COVID-19, and again, for the most part right now, we're doing mitigation, so we're just telling people if you get sick, stay home, and if you've been in contact with somebody who's sick, stay home. So it's kind of up to you to figure it out. If you're doing containment and we get a positive case, then most of the time when we do this contact tracing, the person already knows, right? Because they're probably friends or work with or colleagues, or so they might already know because they're kind of in contact with each other, social media or whatever. So it's not uncommon when you call them up, they say, yeah, I know you're talking about, my buddy, and yeah, I know I'm already home isolating. So some people are already doing it, or home quarantining, I should say. And otherwise, they're given, if they're not aware, then we just give them the general situation where it came, the day it happened, and then we put it out. So public health can do that. Otherwise, public health can do things that sometimes you can't do otherwise in healthcare because it's something we call HIPAA with privacy. But public health is exempt from that because it's protecting the health of our population. So, we get into this with sexually transmitted diseases and other infections, tuberculosis. We do in public health, we do contact tracing and identification all the time. So,
well, how far back in that contact do you guys?
Yeah. So let's say you and I go out and decide to I don't know, have a jiu-jitsu meet together, okay? And then you 4 days later come down with COVID-19. I'll get a phone call about that, only if I'm within 48 hours of that time frame. Because what we know now is that pre-symptomatic shedding of virus, which is having the virus come out of you before you get symptoms of it, is almost always within a 48-hour time frame. So if it's before 48 hours, it's not a concern. So it's 48 hours and then all the way up to the time that you get symptoms and get put into isolation yourself. So usually we're talking about a 4 or 5 day window. And that's why we tell people, hey, if you get sick, stay home, because you're not going to have as many contacts, right? Because you're going to be by yourself, staying home, or with your family, and you're not going to work. You're not, going out to eat. You're not doing those things. So it'll be really important when we relax our social distancing, because now we're kind of saying just assume everybody has it, right? So everybody stays home. Everybody does social distancing. Everybody does the sheltering in place.
Well, you talk about looking toward the middle of May or the end of May, where hopefully some things can start to relax a little bit. Is there a specific, number in terms of cases per day or deaths per day here in the triad that is a number?
Yeah, numbers not so much. I think we look at overall curves, and actually the time when things start to get relaxed, my opinion is when they should get relaxed, and the mayor's opinion, and the governor's opinion, and the guy who owns, the auto store's opinion are all going to be different, right? Because everybody has a little bit of a different stake in it. So, when I say end of May, I'm talking about what I would like to see What our politicians end up balancing off with other things, we'll have to wait and see. Because it is a balancing thing, right? And with saying that, again, I said it last week, but I really want to put a plug in for supporting our local businesses. And because they're really hurting, and they're really striving to be there for us. And takeout food, it's safe. It's really not a concern. If you're worried about the plastic container that you brought it home in and you brought your take-home food, you open it up, put it on your own plate, and then wash your hands. And if you're concerned, but we really have not identified that kind of takeout or even picking up your groceries at the grocery store is really a problem. So. The cleaners and things like that, let's keep supporting them. These guys are staying open for us, so to help make our lives a little better during this. So let's support our local businesses. Any other questions?
Going back to if it comes back in full force, which is 50% chance, are we prepared as far as equipment like ventilators goes, rather than just PPE?
Yeah, so the question about a 50% chance of going over ICU capacity would be if we release social distancing and shelter in place after 2 more weeks, rather than waiting to the end of May. I mean, and this again are mathematical models, okay? So it's not that's why we say 50% chance. It's like predicting the weather, right? Will we have enough ventilators and stuff? Well, by definition, if we're exceeding ICU capacity, if we do that, then the answer is maybe not. We're trying to get more and have planning right now for surge capacity should we need it. That's why us in healthcare and hospitals are saying, hey, let's do the social, if we're going to do all of the social distancing and sheltering in place right now and go through this, let's do it long enough so we don't get to that point, right? So it's kind of like, why do something halfway? If you're gonna do something, go the distance, get the job done, complete the task, and then find a nice, safe way to get down. Because we don't want to get to that point of having to look for ventilators like New York City or Detroit. If we stay on the mesa and then come down normally and naturally, safely at the end, we're not going to have any of that capacity issues. So.
And if you guys don't have the resources to be able to do that, what then? Do you guys have alternate plans in place? We
do, yeah. Everyone has got surge plans in place and how to do things. I mean, people worry about the ventilator issue, but they hear stories like 2 people on 1 ventilator. But that 2 people on 1 ventilator story is being told and retold and retold. That stuff doesn't happen very often, even in places like New York. But yeah, we do have plans to get what we need should that happen. But we in healthcare would rather not have to do any of that surge stuff. We would rather just take care of our patients, whether they have COVID-19 or anything else, in the usual way. And if we keep our social distancing and sheltering in place for the right length of time, we can do that, and we don't have to surge. That's the safest way.
Dr. Roll, we're getting some questions on Facebook, and there's been some in the national news about antibody testing.
Yeah, antibody testing, that's called serology testing, and that's basically means to see if you've had an infection. It probably won't play a role in the diagnosis of acute COVID-19. Like, so let's say, I got sick, I got flu-like symptoms, let's go see if I have it, and getting a blood test that looks for antibodies. That probably won't work very well for that. What antibody testing is going to tell us is how much of a population have had COVID-19. either with moderate symptoms, mild symptoms, maybe even no symptoms. And that's the only way to know. And that's called a serologic survey in our world. So we'll go out and do a population, and then we would say, so let's say 1 out of every 10 people who live in East Winston, West Winston, North Winston, and South Winston, we divide it all up. And we'll ask them to give some blood to see if they've been exposed to it and have had the disease. And with that knowledge, then we can know how susceptible a community might be for a second wave. And we might also be able to tell a little bit more about vaccine strategies and things like that in the end. So it's for knowing more about your community and your population than it is about for an individual. We actually are going to start doing that here at Wake Forest Baptist Health. We have a protocol now in place and support from the NIH and the CDC and Oracle and some other private and public entities to do such surveys here in the Triad region. It'll help us understand our community and how COVID's affected it. So other questions? I got a question. Okay, so Dr. Old needs a haircut. So I need to know, do I let my wife cut my hair? Okay, my wife, who is also an infectious diseases physician, thinks she can cut my hair. Dr. Old is not so sure, and I'm a little bit nervous about this. And so if anyone wants to send in a comment or vote on your Facebook lines about whether I should just let my hair grow out and become a hippie or get my hair cut by my wife. So you guys will have an impact, and I'll do whatever the majority of you think. So how's that a way to wrap up?